Hello everyone, welcome back to my YouTube channel My Cup of PT. In today's video, that is Orthopedic Assessment Part 2, I will be discussing all those points that were not covered in the Part 1 Orthopedic Assessment. So if you haven't watched the Part 1 Orthopedic Assessment, please watch that video. And now we can start with the on observation part because we have already completed the history points in the Part 1. So starting with the on observation. So on observation is something that we will be looking on the patient. It is generally known as inspection. Okay. So you have to ask your patient to remove his or her shirt to closely observe the affected area. Okay. Then you have to inspect the front, the back and the lateral side of the affected area as well as the full body. Okay. Now it includes the general condition of the patient. You will be able to see if the patient general condition is poor, good or fair built. You can also include a point here that is built. The patient can be ectomorphic, that is thin, mesomorphic, that is moderate build, and the endomorphic is obese. Okay. So wasting of muscles, look for wasting of muscle, then see if there is edema or not, and please mention which scale you will be using and the grade. Mostly people use modified Ashworth scale. Okay, let me correct it, modified Ashworth scale, and then you have to mention which grade it is. Okay, then if any bandages or scars are there, please see that so that you can know which area the scar is there and up to what extent the scar is present. Then see the attitude of flame, supine, sitting, standing, in these three positions. Okay, then type of gait is very important. We know there are some abnormal gaits that are seen in, particularly seen in some conditions such as, let me write here for you guys, fascinating gait, that is seen in the Parkinson's patient. Okay, and the other is scissoring gait. There are many gaits, so you have to see. Okay, scissoring gait is seen in CP, that is cerebral palsy. Okay, so then coming to the bony contours, already I have told you, you have to look for evidence of any asymmetry, any bony deformities there, any scapular winging can be there, swelling can be there, skin changes can be there. Okay, so these all things need to be inspected. Okay, now coming to the on palpation part. On palpation means feel. You have to touch the patient and feel. Not look for that, just feel the warmth, the tenderness, everything need to be palpated. Okay, so tenderness, you have to mention the grade. Here grades are mentioned already, like 1, patient complains of pain, then patient in second grade patient complains of pain and winces is the uneasiness expression on the face of the patient. Okay, then in third grade patient winces and withdraws, he will withdraw the affected part, and in fourth grade the patient will not allow to palpate the joint, that is the patient will not allow the physiotherapist to even palpate the joint. Okay, so after that you can look for the tension and the texture of the skin, temperature, variation of the skin, everything you need to mention here. If the, just wait, let me mention it, warmth is there or coldness of extremities is there, all need to be mentioned. Okay, then you have to look for the spasm. In cervical patient, you have seen that if there is any trapezitis is there or any muscle involved is there, we need to palpate so that we can see is there any spasm over the affected area or not. Okay, you have to look for that. Then type of skin, dry is there or excessive moisture, this all you know already, that in palpation we can mention these things. Then the scar is adherent or non-adherent. If the swelling is there, there is a classification, you can see, this is for a reference only. Comes on soon after injury, if the swelling comes on soon after injury, that is blood swelling. If it comes after 8 to 24 hours, then synovial. Boggy or spongy feeling is there, that is also synovial. If harder tense feeling with warmth is there, that is blood swelling. Tough or dry is callus one. Then leathery thickening swelling is there, that is the condition is chronic. If soft fluctuating it is there, then it is acute. If hard is there, but obviously it is bony. and then thick and slow moving is a pitting edema. Okay, then crepitus, everybody knows that it is abnormal sounds that is mostly seen in the joints. Okay, so this only you need to mention. Okay, now coming to the examination part. In examination there is two classifications, that is sensory assessment and the motor assessment. Before that, what you need to mention in examination is the vital sign, because the vital signs are very important. If this is stable, then only you will be able to do the assessment part or the examination part, that is motor assessment and the sensory assessment. So vital signs include BP, temperature, heart rate, BMI. This need to be recorded first. Then coming to the motor assessment. Motor assessment includes range of motion and feel, capsular pattern, manual muscle testing, resisted isometrics. Okay, so this is all about the motor assessment. There are few more points that I will be discussing in the next one, but before coming to those, let's finish with the range of motion first. Okay, so range of motion, it is there are three types of range of motion: active, passive and active assisted. Active, when the patient perform himself or herself. Then passive is when the physiotherapist will be doing it for the patient, and the active assisted is the physio will assist to complete the motion. Okay, so this is all about the range of motion. This you can read what we all need to see in the active and the passive. When and where pain starts, whether the movement increases with pain or not, pattern of movement. Okay, this you all need to see. Then coming to the end feel. So what is end feel? It is a feeling or a sensation which the physiotherapist detects when the joint is at end of its available passive range of motion. So it is basically a passive technique. Physiotherapist will be performing it on the patient. Okay, so there are two classifications now, that is normal one and the abnormal one. In normal, bone to bone is there, soft tissue approximation is there, the tissue stretch is there. Bone to bone means when the bone will be connecting to the other bone. In this case, the example will be, let me write it for you, elbow extension. Okay, so in elbow extension there will be bone to bone end fill, that is considered to be normal. Then soft tissue approximation. In soft tissue approximation it is knee flexion. Okay, I will recommend you to read David Maggie for this. It's very beautifully explained in David Maggie book about the end fills. There is a table mentioned in the David Maggie book, and the normal and the abnormal end fields are given over there. Okay, if I talk about tissue stretch now, the tissue stretch end field is there in ankle dorsiflexion. Okay, so this you all can see in the David Maggie book. Okay, the table is there, that book. Okay, so abnormal early muscle spasm is there, that is for as a protective spasm following any injury. The late muscle spasm is due to instability or pain. The hard capsular is seen in frozen shoulder, and the soft capsular is seen in synovitis. And there is one bone to bone abnormal, that is osteophyte. If there is osteophyte formation, then the bone to bone in that case will be considered to be abnormal and feel. MT is when specifically it is in the acute subacromial bursitis, and it is also it can be mentioned in those cases also when the patient is not allowing you to touch because of pain. So you can mention MT and feel. Okay, the springy block is seen in the meniscal injuries. Okay, now coming to the capsular pattern. What is capsular pattern first? It is a predictable pattern of the movement restriction when the capsule is involved. And if I talk about the example, that is very common example you guys have seen already. I think so that you guys have would have seen those in the frozen shoulder cases, and it is very common. Okay, so the pattern that is followed in the frozen shoulder patient, the capsular pattern restriction that is followed in the frozen shoulder patient cases is lateral rotation, then abduction, followed by the medial rotation. Okay, I can mention it for you, and this is also given in the David Maggie book. The table is there in which they have mentioned all the joints capsular patterns. Okay, so let me mention frozen shoulder, capsular pattern. Okay, this is a predictable pattern of movement restriction. Okay, and it is only seen when the capsule is involved or any effusion is there. Okay, or any capsular fibrosis is there. So frozen shoulder, lateral rotation, that is external rotation only. Okay, lateral rotation or external rotation, I can mention external rotation, and then followed by abduction and medial rotation. Okay, so coming to the next point, that is manual muscle testing. So you have to mention in this which grade patient is, like every joint of the body you are assessing, and then you have to mention 3 out of 5, 5 out of 5, everything, and the scale name. Okay, MRC grading or any whichsoever you will be using. Then resisted isometrics. So in resisted isometrics, that is coming under the motor assessment, you have to see on contraction causes pain, or if it does, what is pain intensity and the quality. If on contraction there is pain, okay, you will be performing some resisted isometrics on the affected area, and you will see if there is pain on the contraction, then you have to mention over there that pain is present, and what is pain intensity and the quality of the pain. Then strength of the contraction, you have to mention the type of contraction is very important. Okay, concentric, you should know the basics for this. The concentric is the shortening of the muscle. Isometric is there will be the force will be generated within the muscle, or the tension will be generated, but there will be no change in the length of the muscle. In eccentric there will be lengthening of the muscle. Then coming to the joint movements, that is last point in the motor assessment part, that is loose peg position and close peg position. And before that, before starting with the examples and everything, I would like to tell you what is loose peg. Loose peg is an open peg position when there is very less incongruency between the joint or no incongruency. Okay, and close peg is fully congruent when the joint is fully congruent. And it is again, I would like to mention it again, that it's mentioned in the David Mackey book. There are two tables given: the close peg position of the joint and the open peg position of the joint. They have mentioned each and everything over there. Okay, so you have to see. As I'm only covering the assessment format, so I'm not getting deep into it, but you need to see all the joint loose peg and close peg position. Now coming to the sensory assessment, it consists of superficial sensation, deep sensation, and combined sensation. For superficial assessment, for superficial sensation, you need to check pain, temperature, light touch, pressure. Now for this you have to go to the Sullivan book, because if you want to make your assessment strong, you need to go through books. You have to clear your basics. Okay, how to assess the pain, temperature, there are various techniques given in the Sullivan book. Okay, so deep sensation, movement sense, that is also known as kinesthesia. Let me mention this for you guys. And the position sense is proprioception. This thing are given in the Sullivan book. Okay, if you want to get deep into it, or you want to gain knowledge about this, so you should read this book. Okay, then combined sensations, stereognosis, tactile localization, 2-point discrimination, gresthesia, these all techniques are over there. And even I would recommend you guys that your basics should be clear, because then only you will be able to assess the patient. Otherwise there is no use of learning this format as it is. Okay, if you are not knowing the techniques. Okay, now coming to the reflexes part. Superficial reflexes are there, deep reflexes are there. Okay, so superficial include the corneal, the abdominal, the plantar reflex, the cremasteric reflex. Then the deep one are the bicep, tricep, Babinski, knee jerk, ankle jerk, and there are also the abnormal reflexes that you guys should know. Let me mention here. Just wait. Okay, abnormal are Chadok is there. Okay, open hem is there, So this all you need to mention in your assessment. Then grading is there. You need to mention which grade is there. 0 means absent, diminished is 1, 2 is normal, the third one is brisk, and the fourth is exaggerated. Then dermatomes, myotomes should be mentioned, and the next is limb length, leg discrepancies are there. Okay, so apparent length should be recorded and the true length should be recorded. Then coming to the special test, the special test need to be mentioned as per the affected joint. Okay, these should be on the tips. If you want to clear your doubts, you can watch a video, physio tutors. Okay, they have mentioned everything in a very short video, so you can refer those videos. Then functional assessment, you need to see if the patient is ambulating through wheelchair, and if gait pattern is abnormal, which gait pattern is there. Then if patient is independent or dependent, transfers of the patient, how they are, and this all comes under the assessment part of the basically the examination part. Okay, then gait assessment, type of gait, stride length, step length, everything. If you feel that it need to be mentioned in the assessment, then you have to assess it correctly and mention it accordingly. Okay, then ADLs and this VAS and NPRS scale is just a pain scale. We have already mentioned in the previous video, okay, about this. So investigation, the x-ray, if you feel that there is any investigation required, so you can prescribe the patient to go for the same CT scans, x-ray. Okay, then if any abnormality is seen, the clinical impression should be mentioned, any joint space reduction or anything is there. And yeah, one more point, in x-ray you need to mention which view you want the patient to have a x-ray, so AP view or lateral view. Okay, this need to be mentioned. Differential diagnosis. Now differential diagnosis is all those diagnoses that you will be that you will be guessing through the assessment, and the final will be written over the final diagnosis. Out of these differential diagnosis, you will make a final diagnosis. Okay, then goals, short term goals, long term goals, these all need to be mentioned. Short term basically include those you want to see in initial days, those changes that you want to see in initial stage or initial days of the treatment, and the long term is the maintenance part. Okay, basically the rehab. Then treatment plan, explain the electric modalities, manipulation or mobilization. If it is done, then you have to mention it. And exercises, you have to make an exercise regime for the patient. The splints and the assistive devices should be mentioned, and the home program if needed. If patient need any home program specifically for the frozen shoulder, if you want the patient to perform exercises at home, so you can make a home program as well. So this completes the orthopedic assessment. I will recommend you guys to watch the part 1 and the part 2 so that your basics can be cleared. Okay, so if this video was helpful to you, please hit the like button and do subscribe to my channel. Thank you for watching.